To introduce Dr. Keith Yeates. He is the Ronald and Irene Ward Chair in Pediatric Brain Injury and professor at the University of Calgary in psychology. During his 30-year career, his research is focused on childhood brain disorders, especially traumatic brain injury. He is one of the top-cited authors in pediatric TBI, a co-lead on the CDC expert panel on mTBI among children and adolescents, a panelist at the most recent ISG Concussion and Sport Group Conference, and a member of the American Congress of Rehabilitation Medicine Consensus Group for the Diagnostic Criteria of mTBI. Dr. Yeates is also the current inaugural chair of the Canadian Concussion Network and editor-in-chief of Neuropsychology. He has been ranked as one of the top 10 most influential neuropsychologists in North America. Suffice to say, we are delighted to have Dr. Yeates as our speaker for today's webinar. And without further ado, I will pass it over to Dr. Yeates.
Thanks, Haley. I want to thank IBIA and the Concussion Interest Group for inviting me to speak today. I'm going to do the magical share screen and then pop this on to presenter mode. Hopefully that's what you're seeing. I think that's what you're seeing. So yeah, we'll go ahead and jump right into it. Just a couple of quick disclosures. I have a couple of grants from CHR and NIH. I get a stipend from APA, have some small book royalties, some honoraria from various boards I sit on, and I do some occasional medical legal work. Just for those of you who haven't been to Canada too much, everybody seems to know where Toronto and Vancouver is and maybe Montreal, but frequently we don't know where Calgary is. We're situated out here in the western part of the country, just east of the beautiful Canadian Rockies. Some of the most beautiful places to hike, ski, and do outdoor activities in the world. So if you've never been here, highly recommend paying a visit. So gone to this. So concussions happen in lots of ways with kids, a lot in sport and recreation, but other in ways we would never anticipate. I really do wonder who took the film of the young man with the bat. And I don't know that either of these resulted in concussion, but the point is that they do happen in many ways. Concussion is a major public health burden. I'm sure I'm preaching to the choir here. Probably millions in North America, particularly when we try to account for children who don't come to the hospital, don't necessarily even come to medical care. A nice article in Pediatrics back in 2016 by Fred Rivara and his colleagues trying to get at that number. Concussion and mild traumatic brain injury has been identified as a target by all the leading health and research agencies. And clearly, at least before the pandemic and starting to happen again now, a really hot topic, both in the media and the scientific literature, whether it be about second impact syndrome, persisting post-concussive symptoms, or more recently, chronic traumatic encephalopathy. Concussion gets a lot of attention, and it's interesting if you do a graph of the number of publications with the word concussion, it goes from only a few hundred from around 2010, and suddenly there's a spike where now we're in the thousands of publications per year. But I've been saying for 25 years nearly that even if a small proportion of the folks who with concussion have negative outcomes, concussion is a major public health burden, just given how often it happens. We've seen that in the epidemiology of pediatric concussion. This is a paper we published earlier this year that was led by Crystal Wittervongel, one of our graduate students I co-supervised. And this was data from Alberta, where we looked at the incidence of concussion and related diagnoses from 2004 to 2018. And what you see is a very characteristic, sort of pretty flat, 600 to 700 per 100,000. And something around 2010, we see this rapid increase in the incidence of concussion, of diagnosed concussion, more than doubling over those roughly 10 years. And this has been shown in other studies as well. What I'm sure is happening here is increased identification and recognition of concussion, not a true increase in the incidence per se. But what we do know is we're seeing more and more of them as we have increased public awareness about the disorder. So one of the concerns, of course, is that which kids have persisting symptoms. And one basic question is, how often do persisting symptoms occur? My doctoral student, Leah Chadwick, published a systematic review and meta-analysis back last year in the Journal of Pediatrics, where based on 13 studies, she concluded that 35% of children with concussion will demonstrate persisting symptoms. Those were higher rates for older kids, particularly adolescents and female children, but also much more, not surprisingly, among kids who present to clinics. And if you limit the analysis to those presenting consecutively at emergency departments or acutely, the percentage is more like 25%. So it really doesn't matter how you evaluate this. It also depends on the methods you use. This is a paper published back in 2020 by Andy Meyer that I was part of, looking at how different methods for classifying persistent symptoms affects the numbers of kids identified. And the basic bottom line is, if you use traditional sort of how many symptoms do you have methods, like 3 symptoms, 3 new or worse symptoms, you show much higher rates of persisting symptoms than you do if you use more statistically based techniques like reliable change or normative percentiles. So you really have to think carefully about how you define persisting symptoms. If you use these more robust statistical methods, again, the percentages tend to be substantially lower, probably more in the order of 20 to 25% again. Traditionally, going back to Leishman's classic article in 1988, the debate about the reasons for persisting symptoms has been boiled down to physiogenesis versus psychogenesis, i.e. the argument about whether persisting symptoms after concussion are really a result of psychological versus biological underpinnings. And that classic article was followed up by a very nice revisit of that issue by Noah Silverberg and Grant Iverson now about a decade ago, where again, they reviewed the evidence for the factors involved in the onset of persisting symptoms. Back in 2005, Gary Taylor and I tried to provide a broader biopsychosocial framework for understanding post-concussive symptoms in children in particular, with the assumption being that post-concussive symptoms are a outcome that reflects a variety of different factors, the injury itself, with more severe injuries being associated with worse outcomes, but also what the child brings to the injury and how they react, as well as what their family brings and how they react to the injury. So it's more of a biopsychosocial framework. Moving even more recently, we're beginning to appreciate concussion really as a complex multi-level system with impacts and outcomes at a cellular, network, experiential, and social level. These are 2 very nice articles, thought-provoking articles published in the Frontiers of Neurology several years ago, and that I highly recommend, just thinking about the complexity involved in trying to understand the outcomes of concussion. But what about prognosis? How do we think about predicting the outcome? Today, I want to do several different things. I want to review the so-called 5P score, where we're now able to better predict persisting symptoms in children in the emergency department, and then move on to talk about more specific biopsychosocial predictors, starting with some injury factors like imaging or acute injury characteristics, then some psychosocial factors having to do with pre-injury and post-injury factors in the child and their lifestyle, and then environmental factors, including management and treatment, as well as parenting and the family environment. So let's start with the 5P study. This was really a landmark study conducted in Canada, directed by Roger Zemek, who's an emergency medicine physician at CHEO in Ottawa, Children's Hospital of Eastern Ontario. Prospective cohort study conducted across 9 different emergency departments in Canada, a total of about 3,000 patients. They examined multiple potential predictors of outcomes, followed the kids up across 12 weeks post-injury. Their primary outcome was persisting symptoms at 4 weeks. They did look at a variety of other outcomes. And that study resulted in a really important publication in JAMA back in 2016, where it derived a clinical risk score for predicting persistent post-concussion symptoms. I was fortunate enough to join this study after I came to Canada in 2014. And I want to point out a few things about this risk score. First, it incorporates important demographics. So age and sex are known to be important predictors of persisting symptoms. And in general, literature suggests that adolescents are at higher risk for persisting symptoms than younger children, and also that girls are at higher risk than boys as well. In addition to demographics, 2 factors relevant to the person's history, the child's history, are included. History of prior concussion with the symptom duration lasting a week or longer is associated with a higher risk of persisting symptoms than no history of concussion or symptoms lasting less than a week, and then a history of migraine. And we'll get back to that because it turns out that headache is a really important predictor of outcome in general. Then there are some factors involved in the clinical presentation, some of which have to do with signs, balance problems, or being shown to have a mental status alteration in terms of answering questions slowly. And then 3 specific symptoms: headache, sensitivity to noise, and fatigue. And I'll just highlight headache and sensitivity to noise again, because some of our research that I'll get to a little bit later really begins to highlight the importance of headache symptomatology as a predictor of longer-term outcome. On the right here, we see a receiver operating characteristic curve analysis. And the interesting thing here is that the risk score, which ranges from 0 to 12, was significantly associated with the rate of persisting symptoms at 4 weeks, and much better than physicians were able to predict on their own. In fact, physician prediction was only marginally better than chance, whereas the risk score was predicted around 70% accuracy. And this is just a different way of showing the same data, but essentially shows that if you have a low risk score of 0 to 3 points, you have only about a 15% probability of having persisting symptoms, whereas if you have a high risk score in the 9 to 12 point range, you have a 60% probability of having persisting symptoms. So while not perfect, this represents a major step forward in our ability to predict prognosis. And I just highlight that it incorporates actually a sort of biopsychosocial framework, in that it includes the child demographics, their medical and social history, and their presenting symptoms in terms of the severity of the injury. So my own research has followed on the 5P study, and today I'll be talking a lot about data from the Advancing Concussion Assessment in Pediatrics, or ACAP study as we call it. This was a prospective concurrent cohort longitudinal study where kids were identified and recruited in 5 emergency departments across Canada, and then followed for 6 months. All the study, the recruitment and data collection was completed prior to the pandemic, fortunately, so that we don't have to worry about the influence of the pandemic on this data. The 5 sites all came from the Pediatric Emergency Research Canada network, and were spread across the country, mostly in western and eastern portions of Canada. These were 8 to 17-year-old children with either mild traumatic brain injury or orthopedic injury. For the sake of this discussion, I'm just going to use mild TBI and concussion interchangeably and not get into the nuances of those differentiation. 99% of the kids in this study would have been classified with concussion. A few might have been classified with a slightly more severe injury. Our goal was to recruit 1,000 children. We came close. We had 967 children who were consented. Most of those, around 85 to 80%, did return for their post-acute assessment, and then face-to-face assessments at 3 and 6 months. And the goal to accrue such a large sample was to have sufficient statistical power to test complex models that would combine neurobiological and psychosocial risk factors in trying to understand the outcomes of pediatric concussion. I was really, I think, influenced by the so-called neurobiopsychosocial model, adding the neuro to the front. That's reflected in this nice paper by Mike McRae, Donna Broshek, and Jeff Barth, where they looked at basically, or sort of portrayed how we might better understand concussion by looking at multi-domain predictor variables that are both neurobiological and psychosocial, and considering outcome from a multi-dimensional perspective, ranging from neurobiological health out to life function and quality. So in the ACAP study, we examined a variety of neurobiological variables, including acute signs and symptoms and balance. We collected saliva so that we could look at candidate genes. We have extensive imaging, both post-acutely and at 3 or 6 months. We tested neurocognitive functioning and assessed, of course, sex, age, and importantly, pubertal status, which surprisingly hasn't been really examined in relationship to concussion. And age is often used as a proxy, even though they are not perfectly correlated. And we know that girls actually mature earlier than boys on average. We also looked at a variety of psychosocial factors in the child and in the parents and family. try to get a better sense of which of these factors seems to have the most or carry the most importance in terms of predicting outcome. We also looked at a variety of outcomes multidimensionally, particularly focused on post-concussive symptoms, but also on the impact of headache and sleep problems, and then a variety of measures of functional impairment and using the Glasgow Outcome Scale as a measure of overall status. Even though we know that its sensitivity is somewhat limited in the area of concussion, it turns out that in our study it was sensitive to differences between the mild TBI and OI groups. This is just a quick portrayal of some of the characteristics of the sample. As I said, we had about 967 kids consented in the emergency departments, pretty good follow-up rate, no differential attrition by group. And we've done extensive analyses to show that on the whole, attrition didn't seem to be related to any key characteristics. Kids who were included and not included in follow-ups were very similar. About the only factor that seemed related was some indicators of race and socioeconomic status, with somewhat more dropout of more socially disadvantaged or minoritized individuals, consistent with other studies that have reflected on what factors are associated with attrition. The study was slightly predominantly male, consistent with the demographics of concussion, but still pretty well balanced. About 70% white. The racial distribution was consistent with the demographics of Canada, but I think in the future we need to make more efforts to have overrepresentation of some racial groups, and really nicely equivalent for age at injury and other demographic factors, as well as timing for the post-acute and then subsequent assessments. So let's start with talking about the brain. What role does the brain have in trying to understand the role of concussion? Because, of course, that is the very basis of so-called physiogenesis. And in ACAP, we've done a variety of imaging studies. We've looked at longitudinal gray matter trajectories in a recent paper we published in neurology, led by my former postdoc, Ashley Ware, who's now at Georgia State. We've done longitudinal studies of white matter microstructure using DTI, including NADI sorts of analysis that were led by Ayushi Shukla, one of our former doctoral students. We've done studies of structural and functional connectomes with papers largely led by Ashley Ware, but also by Adrian Onikas, who was a exchange student from Italy that came to work in our lab. And then we've had some more specialized publications looking at spectroscopy and quantitative susceptibility mapping. I can't go into detail about each of these, but I'll summarize them. In general, we found relatively few differences between the concussion and orthopedically injured comparison group acutely, so at around a week post-injury. However, it was interesting that quantitative susceptibility mapping indices in the frontal white matter post-acutely seemed to predict persisting symptoms at 1 month, as well as the 5P score did, and in fact incrementally added to the accuracy of the 5P score, which worked just as well in our sample as it did in Zemek's original study. We've also begun to do some work that Ashley's leading together with colleagues at Georgia State that suggests that machine modeling might be able to take advantage of the complexity and high dimensionality of the data and actually be able to discriminate between the concussion and OI groups in ways that we can't necessarily do in more simpler statistical models, but that work is still in progress. So stay tuned at that level. But what's really interesting is that we do see later emerging differences on virtually all of these indices of imaging, but they vary by age, sex, and symptom status. Symptom status is particularly important so that in general, we see more evidence of differences from the orthopedically injured comparison group in the kids who show persistent symptoms, and fewer differences in the kids without persisting symptoms. But we also see that moderated by age and sex, so that some of the effects that differentiate between symptom status are actually somewhat different for girls and boys and for older versus younger children. Together with our own work, as well as some recent work by Andy Mayer that he's been working in a very similar kind of sample, we're beginning to see some indications that raise a question about perhaps accelerated aging in kids with concussion who have persisting symptoms that might help account for those differences. We've become very interested in post-traumatic headache. Leading up to our own work, there have been several different studies published really suggesting that post-traumatic migraine phenotypes are associated with much worse outcomes after a concussion. But those studies had a number of limitations, including small sample sizes. They were limited to athletes, often limited to only adolescents. Some of them were recruited only from specialty clinics where there's a significant concern about ascertainment bias. Many didn't have a comparison group, particularly an orthopedically injured comparison group, or didn't control for other risk factors. So Jackie Van Ursel, who was a postdoc with Roger Zemek, took some of our data to look at the relationship between headache phenotype and concussion outcomes. We took symptom reports at 1 week and classified kids into 5 different groups. They were classified as having post-traumatic headache. If they reported a headache, sometimes or often on a 0 to 3 scale, so they had to report a headache with a rating of 2 or 3. If they reported headache, they were classified as having a migraine phenotype if they endorsed nausea or both photophobia and phonophobia, or all 3 of those symptoms, in accordance with classification schemes existing for post-traumatic headache and migraine. They were classified as having no migraine but post-traumatic headache if they reported headache but not migraine features. And they reported as no post-traumatic headache if they reported headache never or rarely, regardless of whether they reported nausea, photophobia, or phonophobia. And then we also included the orthopedically injured group of kids, restricted those without post-traumatic headache. So they were reporting headache at a 0 or 1 level in the post-acute assessment. We tested the association of those 5 groups, those phenotypes, with outcomes in comparison to the 5P clinical risk score and a variety of other covariates and confounders. And the outcomes we focused on were post-concussive symptoms at 3 months and quality of life at 3 months post-injury. We're also concerned with the clinical significance of the association. So we looked at the association of post-traumatic headache phenotype with reliable change. Reliable change is a way of statistically determining if a child's post-injury symptoms are statistically significantly higher than expected after the injury compared to retrospective ratings of their pre-injury symptoms, using the orthopedically injured kids as a normative reference group. So I don't expect you to try to go through this whole table, which shows some of the initial post-injury characteristics, but I just highlight a couple of things. First, we had a substantial sample in all 4 of the groups that we were interested in, ranging from 134 to 254. So we had good statistical power here to compare these groups. Another thing that was very interesting was that compared to the kids in the no migraine, no headache, or orthopedically injured group, the kids with a migraine phenotype were more often female and white, more likely to report a history of concussion with symptoms lasting a week or more, had a higher 5P risk score at the ED visit, and reported higher pre-injury symptoms and lower pre-injury quality of life. This just really highlights that what children demonstrate after their injuries is very much a function of what they bring to the injury. So kids who have post-traumatic migraine phenotype are not indistinguishable from those with other types of phenotypes pre-injury. In fact, there are certain risk factors that put them at risk. And we did covary for these sorts of pre-existing differences. So here's some initial findings. What we consistently see is sort of a dose-response effect when it comes to symptoms, with the kids with migraine phenotype having the highest level of symptoms, the kids with non-migraine phenotype following in between, and the kids with no post-traumatic headache being very much like the kids with orthopedic injury. So that, in fact, if you had a concussion but you didn't report significant headache at 1 week, you generally were functioning much like the kids with orthopedic injury who had no headache. When we looked at quality of life, things were a little bit less clear. In general, the kids with migraine phenotype did worse, but less so than was obvious with symptoms, and often these differences were not statistically significant. But one of the things we realized is the 5P risk score, as I mentioned earlier, includes symptoms of migraine, i.e. headache and photosensitivity or sensitivity to light. So what we did is we modified the 5P risk score to take out those two symptoms. And when we did that, we found significant differences in quality of life between the children with migraine and the no post-traumatic headache groups for the total and physical functioning scores off the PEDS-QL, as well as between the migraine and OI groups for school functioning. So when we took out the symptoms that themselves might be indicative of migrainous phenotype, then we did find patterns of quality of life, lowered quality of life that were similar to those for symptoms. Also, it's worth mentioning that the kids with the migraine phenotype were twice as likely to report reliable increases in total symptoms compared to the group without post-traumatic headache, and 3 times more likely to report reliable increases in somatic symptoms other than headache compared to the no post-traumatic headache group. So these are significant and clinically meaningful changes that kids with post-traumatic headache that has a migrainous phenotype show compared to other groups. But the injury isn't everything. This was a paper we published now a decade ago, led by Kelly McNally, one of my former postdocs who's still at Nationwide Children's Hospital. And in that study, which was based on a different prospective study we had done, we found that demographics and premorbid child and family factors accounted for more variance in outcomes and symptoms than injury characteristics did. So that makes us wonder about what are the things that make a difference. So using the ACAP study and a sub-study led by Quinn Doan, who was one of the PIs at BC Children's Hospital, we looked at retrospective ratings of pre-injury psychosocial functioning to see how they were related to post-concussive symptoms. This is a paper published this year in Journal of Head Trauma Rehabilitation. The first set of findings that I'll bring to your attention show that for emotional problems and conduct problems as rated by the parents, kids with higher levels of those difficulties tended to show bigger group differences. That is, the effects of concussion were more pronounced in kids who had more pre-injury emotional and conduct problems than in kids with fewer. This was sort of in accordance with what we thought would happen, is that we expected that perhaps the effects of concussion would be more evident in kids with pre-existing difficulties. But we found a somewhat more surprising but interesting pattern of findings when we looked at ratings, particularly of hyperactivity, but also of peer problems. In those instances, we actually found stronger group differences at lower levels of those particular types of difficulties. You can see that here where the difference between the mild TBI and the OI groups are larger at lower levels of hyperactivity, whether it's rated, whether the symptoms are rated by the parents or the child. And we also saw something a little bit similar with peer problems, where fewer peer problems were actually associated with a bigger difference between groups. Our thinking here is that perhaps what happens is that, particularly for hyperactivity, is that perhaps the symptoms of concussion are just hard to discern, or more difficult for families to discern, or kids to discern, if you already have significant levels of inattention, impulsivity, and hyperactivity, and that perhaps it's easier to perceive the effects of concussion because the relationship of the hyperactivity to symptoms was still generally positive in both groups. We've also looked at psychological resilience. This builds on work by my former doctoral student, Christiane Lalaberta Durish, that she did with Brian Brooks and me with a couple of different papers, suggesting that psychological resilience, or the ability to adapt to adversity, is a significant predictor of symptoms, and that higher resilience is associated with less persistent symptoms. But recently, my one undergraduate honor student, Ali Hassan, really brilliant young man who's just recently started medical school at the University of Alberta, did a follow-up analysis using data from the ACAP study to look at psychological resilience and post-concussive symptoms. One of the first things we noticed was that psychological resilience itself seemed to potentially have been affected by the injury, so that we saw pretty significant group differences post-acutely between the mild TBI and OI groups and psychological resilience that lessened with time, although were still modest and significantly different even at 3 months and 6 months. This led us to think about psychological resilience as a more dynamic construct that might be affected by the injury as well as affecting symptoms. And so we did something called cross-lag panel analysis to try to understand the relationship between psychological resilience and symptoms over time. And I can't go into all the details, but suffice to say that when we looked at this in a variety of different ways, the evidence suggested that the relationship between resilience and symptoms may be bidirectional, so that symptoms affect resilience, but resilience affects symptoms. And this sort of interaction occurs over time and strengthens with time. And it's just as true of kids with orthopedic injury as it is of kids with concussion, so that the effects of resilience may not be unique to concussion, but may affect symptomatology in general and be affected by symptomatology over time. We've also been interested in how physical and cognitive activity may be related to the outcomes of concussion in terms of these kinds of lifestyle factors. Using the data from the 5P study, Ann Gruhl led a nice analysis showing that early activity and increases in early activity was actually associated with a decreased risk of persisting symptoms. This is consistent with the literature that's growing to show that early exercise may be an effective treatment for concussion. I've also been involved in a nice study by Ginger Yang, my colleague back at Nationwide Children's Hospital, where we've looked at how physical and cognitive activity are associated with post-concussive symptoms. And again, we see an interesting mild evidence of bidirectionality, where the amount of symptoms affects physical activity, but physical activity in turn affects symptoms. We also found, interestingly, in this other paper published back in 2021, that school attendance seemed to be associated with a decreased risk of persisting symptoms. And that was followed up by a more recent study published again out of the 5P data, led by Chris Vaughn, again suggesting that early return to school is associated with a decreased risk of symptom burden. And we have a paper that's under review now out of the study with Ginger, where we actually looked at cognitive activity in a much more perhaps objective way, trying to measure cognitive activity, and are again finding that higher levels of cognitive activity post-acutely seem to be associated with a decreased risk of persisting symptoms. All of which is to say that I think we're getting an increasing amount of data suggesting that persisting symptoms can be reduced by encouraging children to return to their usual physical and cognitive activities on a fairly rapid basis compared to our previous levels of recommendations. We've also examined screen time because, of course, we tend to traditionally recommend that kids avoid screens at all costs after concussion. And Rebecca Mannix and her group did a nice randomized clinical trial looking at the effects of recommending abstinence from screen time versus permitting screen time in the first couple of days post-injury. And they did find that kids who were abstinent or recommended to be abstinent from screen time recovered in about 3 days faster on average than kids who were permitted to have screen time. But I just point out one thing is that the kids with that were recommended to be abstinent from screen time actually did engage in screen time, just as at a much lower rate than the children who were permitted to have screen time. So that might suggest that, again, we continue with that recommendation, but it might be that it's not quite that simple. In a very nice analysis that Molly Carncross led, Molly was a postdoc with Noah Silverberg at the time we did this study, and recently published this just last year. We looked at early post-injury screen time across the entire first week post-injury and how that was associated with concussion recovery. And I'll just draw your attention to what we thought was a very interesting finding, which is that essentially we found that very low and very high levels of screen time were both associated with more pronounced effects of concussion than moderate or more medium average levels of screen time. And interestingly, when you go into the literature on screen time, and what we had Sherry Madigan on this paper, Sherry is an expert in screen time, that Goldilocks effect is one that's also been documented in children, healthy children, whereas too much and too little is detrimental, and the average amount of screen time seems to be associated with better outcomes. And the thought being that restriction of screen time for too long may actually deprive kids of opportunities for social interaction and positive sorts of experiences, whereas too much screen time, as most people are concerned about, may really limit them from engaging in other things. It could be potentially associated with more symptoms. We also found that screen time was not predictive of symptoms past 4 weeks post-injury. So there don't seem to be long-term effects of early post-injury screen time. So we basically end up recommending after the first couple of days, where it's probably a reasonable recommendation to try to minimize screen time, to return to more moderate levels of screen time after that period. We've also been interested in family and parent influences on the outcomes of concussion and mild traumatic brain injury. Leah Chadwick, who I've already mentioned, and Mika Marble, who was a former honor student of mine, who's now in the graduate program here, did a very nice scoping review that's been accepted for publication in the Journal of Neurotrauma, where they found 15 studies with about 2,500 participants that examined the interrelationship of family and parent factors with persisting symptoms. Interestingly, the evidence suggests that concussion alone doesn't necessarily produce more parent distress or poorer family functioning than other injuries, but the occurrence of early post-concussive symptoms in kids with concussion may be predictive of subsequent parent and family functioning. On the other hand, pre-injury or acute parent and family functioning seems to predict post-concussive symptoms, so that more parent distress and worse family functioning is associated with worse symptoms. So what we seem to be finding here is evidence of a bidirectional relationship between family and parent characteristics and children's outcomes, much like what we found in the cases or studies of children with more moderate to severe injury. So that families and parents certainly influence kids' symptoms, but they're also the children's symptoms can influence how families react. So this sort of bidirectionality theme is one that I think comes up again and again when we look at the effects of child characteristics or environmental characteristics, including family and parent, on the outcomes of pediatric concussion. Okay. But what about treatment? So in the most recent consensus conference that was held in Amsterdam last year, it was based on a variety of systematic reviews, and my colleague here in Calgary, Catherine Schneider, led a nice review of the interventions for concussion. And unfortunately, there's still a relative paucity of evidence, despite all the interesting concussion, because RCTs are difficult to do and hard to sometimes get funded. There's only 13 studies that could be found for this particular systematic review. It did provide evidence that cervico-vestibular rehabilitation and vestibular rehabilitation may be effective for children with dizziness and neck pain and headache, and that active rehabilitation and collaborative care may be effective for reducing persisting symptoms. But again, the evidence was somewhat limited. I think one of the reasons, at least for this in part, is that all the systematic reviews for the consensus conference were limited to studies that were predominantly or exclusively of individuals with sport-related concussion, whereas there is some evidence of treatment going outside of that particular population. We've increasingly become interested in the effects of early exercise. This was a RCT that I was part of, led by Andréane Ledoux and Roger Zemek, again at CHIO, published back in 2021. It compared recommendations for early activity versus more traditional reduced activity right in the emergency department. And the two interesting things about this study: one is that compliance was disappointingly low, largely because the kids who were recommended not to engage in activity did it anyways, because kids are going to often ignore recommendations. So that we weren't too surprised when we did a traditional intent to treat analysis that there was no significant effect of the intervention. But when we followed that with a per protocol analysis, where we limited the analysis to kids who seemed to have complied with the directions, i.e. the early activity kids engaged in early activity, and the kids who were randomized to restrict their activity did so, we found lower symptoms at 2 weeks post-injury in the group that engaged in early activity. We also found that reliable increases in symptoms and delayed recovery were less likely in the early activity group. So we're increasingly building on John Leddy's really groundbreaking work. We're getting evidence that early activity and early exercise probably is an effective way of treating virtually all concussions. was part of a nice randomized controlled trial led by Karen Barlow, a neurologist who's now in Brisbane, Australia, but was here in Alberta previously, looking at melatonin. There's been a lot of interest in melatonin as a potential neuroprotective additive or supplement. Disappointingly, melatonin didn't seem to have an effect on post-concussive symptoms, which was the primary outcome, but we did find that melatonin improved sleep in kids with persisting symptoms. And of course, sleep and persisting sleep problems are not uncommon after concussion, and kids who have sleep disturbance tend to have more symptoms. Those with more symptoms tend to have worse sleep. Again, that bidirectionality. But in this secondary analysis published a couple of years ago, we did find that melatonin could help with sleep for kids with persisting symptoms compared to those receiving a placebo. We've also looked in terms of sleep at a more psychological or behavioral intervention. This is a study led by my colleagues Leon Tomfor, Madsen, and Brian Brooks, looking at cognitive behavioral therapy for insomnia with an early trial. And the most interesting thing about this is it not only led to a significant reduction in reports on the insomnia index, but also we saw this interesting trend towards fewer post-concussive symptoms overall in the children who received the CBTI. The sample size was really not powered to find that to be statistically significant, but it was intriguing and raises the question of whether or not interventions need to be focused on the entire array of symptoms or can focus on particular symptom complexes and get a sort of secondary benefit of reducing symptoms overall, given the bidirectional relationship we see between symptoms and other outcomes. Fred Rivara's group did a very nice RCT on collaborative care. This is a fairly intensive intervention combining cognitive behavioral therapy for children, training in family, family system sort of intervention, and then care management. So it's a really intensive intervention. They did find sustained positive effects of the intervention on both post-concussive symptoms as well as quality of life. They're now conducting a trial that will attempt to isolate the active ingredient here by comparing the three major pieces of collaborative care to see how it may affect both generally persisting symptoms, but also more specific outcomes. I'm on the data safety monitoring committee for that ongoing trial, and I was also involved on the DSMB of the original trial. So very interested to see how that proves out. So all in all, we have faced a number of challenges in prognostic research when we try to understand and predict the outcomes of concussion in kids. There's a lot of heterogeneity. Symptom trajectories vary from child to child, and only some children have persistent symptoms. We definitely are beginning to increasingly recognizing that these outcomes are multiply determined, and we need to consider a range of predictors within a biopsychosocial or neurobiopsychosocial model. And we really need prospective longitudinal studies with large samples that allow us to parse trajectories and examine these multiple predictors. And I'm just going to share some work in progress to give you an idea of how we're starting to tackle that with the ACAP data. So these are spaghetti plots, i.e. each line horizontally represents an individual child in the ACAP study. These are for ratings of cognitive symptoms or somatic symptoms by children or parents. And to break it down, put it most simply, a red indicator suggests they were symptomatic, and a yellow one suggests they're not symptomatic. And those are plotted across the 25 weeks of the study. So up here you see there are some kids who report cognitive symptoms, reliable change, reliable increases in cognitive symptoms or being symptomatic across the entire time, whereas many kids never report being symptomatic in terms of cognitive symptoms. You see similar patterns for parent ratings of cognitive symptoms, child ratings, and parent ratings of somatic symptoms. So we took those sort of individual trajectories and subjected them to a statistical technique called latent class growth analysis, and pretty consistently found evidence for 4 or 5 different trajectories with time. In this case, these are the somatic ratings of somatic symptoms by the children. And in this case, we found these 4 trajectories. We have a slow recovery group that takes almost 10 weeks to basically get to the point where they have a zero probability of increased symptoms, somatic symptoms, or being somatically symptomatic. We have a chronically symptomatic group that even at 25 weeks post-injury still has greater than a 60% probability of being symptomatic. We have a very rapid recovery group here in the green that by roughly around 2 weeks post-injury basically are down to a zero probability. And then we have this interesting group here in the blue that I call the late onset or relapse and remit group. And the reason for that is that when we sort the children into the 4 subgroups and look at their individual trajectories, if we look here at the late onset relapse and remit group, what we see is that unlike the other 3 groups, these kids sort of porpoise back and forth between being symptomatic and not being symptomatic. Some of them aren't symptomatic at all until 10 or 15 weeks post-injury. So this is a very interesting group. Here's the rapid recovery group, mostly yellow, because when they are symptomatic, they're only symptomatic for a short period of time. The slow recovery group, where they're symptomatic for 5 to 10 weeks and then are largely asymptomatic, and then the chronically symptomatic group. And again, each of these lines is an individual child. And you can see that in the chronically symptomatic group, most of those children are remaining symptomatic across the entire course of the study. So what differentiates those groups? Well, we looked at have begun to look at a variety of characteristics, demographics, injury severity, and socioeconomic status. And I'll just point out a couple of interesting findings thus far. First, there's a major difference in sex representation in the groups in this particular case, where males are much more likely to be in the rapid recovery group and females, girls, are much more likely to be in the chronically symptomatic group. And that's consistent with what we already knew, which is that sex is predictive of symptom status, particularly based on self-report ratings. We also found that the 5P score differentiated the groups, so that the rapid recovery group in particular showed the lowest 5P score, although you can see here that the differentiation isn't super high, and that's partly because we're not predicting symptom status just at 4 weeks, we're predicting symptom status across time. So the 5P rule was set up to predict more acute or short-term symptom status and is related to longer-term outcomes as well. We also found interesting differences in socioeconomic status, so that the chronically symptomatic group had the lowest socioeconomic status, whereas the slow recovery group had the highest interesting socioeconomic status. We also found that the total number of acute symptoms in the emergency department was predictive of outcomes. Fairly few clinical signs or symptoms or traditional measures of severity were indicative, although it was interesting that nearly 30% of the kids in the chronically symptomatic group had been referred for neuroimaging at the time of their injury, whereas only about 10% of the rapid recovery and slow recovery groups were, indicating there may be some subtle differences. At a multivariate level, when we plugged these factors in, we found that sex, the 5P score, and material deprivation or socioeconomic status were all remain predictive. I didn't have total symptoms in that particular analysis, so I'm sure it would be predictive as well. And in just some quick follow-ups, we have seen interesting differences between these trajectories in certain parent and family characteristics. So when we look at the trajectories of symptom status in kids, what we see is that we really do need to take into account biopsychosocial thinking, because it seems like all 3 of those levels, biological, psychological, and social, make a difference. So in parting, I would say that we need to seek simplicity, but distrust it. This is a nice paper that now is getting a little aged on the so-called chaos or embracing chaos, which is what I sometimes feel like we're dealing with concussion. What we know is concussion results in persisting symptoms in some children, but there are lots of risk modifiers, including the injury characteristics, variations in the symptoms. Which symptoms are we talking about? Who's reporting them? Important developmental variations in terms of age at injury and time since injury, major child characteristics ranging from sex to genetics. I don't have time to go into it, but we're finding some very interesting polygenetic influences on outcome, cognitive and brain reserve, premorbid adjustments, resilience. All of those are factors we found are related to outcomes. And then a variety of environmental characteristics, socioeconomic status, family functioning, Parental protectiveness, we've got some new analyses we're doing now showing that parental protectiveness is related to symptoms, and then how we manage and treat symptoms. All of these are major factors in predicting whether or not kids have persistent symptoms. So take-home messages are that outcomes are really variable within and across children, although fortunately, most children do seem to recover within about 4 weeks of their injury, and our ability to predict recovery is getting better. We need to remember that outcomes are influenced by 3 major sources, not just the injury itself, but the child who's injured and the environment in which the injury occurs. For determining prognosis clinically, it's important to assess pre-injury status as soon as possible after the injury if you don't have true baseline information, because retrospective biases may increase with time. And it's important to assess not just the injury characteristics, but non-injury related factors, and consider the use of prediction rules like the 5P score, which now have been validated in outpatient settings as well as in ED settings. I just close with a quote I've always loved by Sir Charles Simon, saying the symptom picture depends not only upon the kind of injury, but upon the kind of brain, and I would add what shaped that brain, the child's environment, and particularly family and parent factors. I would just bring your attention to recent pediatric concussion guidelines that go into much more detail about these, and most recent being the consensus statement from Amsterdam, or the CDC guidelines, but I also would highly recommend the Ontario Neurotrauma Foundation guidelines. It's a living guideline for pediatric concussion that's updated regularly. And finally, just mention the Canadian Concussion Network. We'll have our annual meeting next year in Ottawa, and we're always looking for folks to come and hear about the good work on concussion that's happening in Canada, not just research-wise, but in terms of knowledge translation and trying to have a significant public health impact. I want to thank all of my collaborators. This is really very much a community group village effort, as well as all the organizations that have funded or supported my work. And then I'd be happy to take questions. Thank you.
All right. Thank you so much, Dr. Yeates. And yeah, for the audience here, if you do have any questions, feel free to raise your hand if you want to voice your question, or you can go ahead and put your question in the chat and I will go ahead and screen those. But just to get us started here, I actually have a couple questions for you myself, Dr. Yeates. I'd love to ask you to dig in a little bit deeper under those differences, those biopsychosocial differences that we saw on those last couple slides, where we looked at the recovery time differences in males and females and those with different socioeconomic status indicators. Why do we believe currently, or why do you believe currently, that there's a difference in recovery time for those groups, the sex differences and the SES? Is it differences in subtypes? Is it differences in time to treatment? What do you think is going on there?
Well, we can only speculate at this point, but I do think actually that sex differences and differences psychosocially based on socioeconomic status themselves probably reflect a biopsychosocial influence. So we know there are differences between boys and girls and things like neck strength and rapidity of psychosexual maturation that might perhaps make girls more vulnerable. But we also, of course, know that girls in general, when you see general population-based studies, tend to report symptoms more than boys do. Is that because girls tend to over-report? Is it because boys are socialized to under-report? Or is it just that's their actual experience and maybe boys and girls tend to have different symptoms? I don't think we have good answer to those questions yet. I think all of them are possible differences. We published a paper based on another prospective study of mine examining sex differences. We found stronger evidence for example, for differences in symptom reports, but we didn't find evidence of sex differences in cognitive outcomes. And we found the differences in symptom report to be somewhat more pronounced on self-report than parent report. So I think there are probably multiple influences operating there. And actually, I think that's a really important next step, is to try to get a better handle on why outcomes for girls might be in some instances worse than they are for boys, because trying to figure out why that's the case might help us lead to better intervention. In terms of socioeconomic status, again, I think multiple things are likely operating, ranging from there's some evidence, some really nice work suggesting socioeconomic status is associated with brain reserve and cognitive reserve. So maybe, in fact, kids that come from lower SES backgrounds are more vulnerable to the effects of injury because of the long-term effects of socioeconomic disadvantage and social determinants. But also we know, just as another example, that access to care is restricted and often limited for individuals from lower socioeconomic backgrounds. And we've seen that in a different epidemiologic study we did here in Alberta. So it could range from everything from pre-existing differences between the groups to the fact that they can't get the sort of early intervention or care perhaps that provides better outcomes. So I think again, that's another one we need to tease apart because just knowing socioeconomic status is related to outcome is just a first step. It doesn't tell us what's the mechanism, why is that operating, and that's where I think so hopefully we can address some of those with the data from ACAP, but I think we're going to need future studies as well.
Yeah, I absolutely agree with you. And once again, there's some bidirectionality there, the way they come in and the way that they're, treated and intervened later, it depends. We do have one question in the chat here from Joseph. He is asking if there have been any recent studies looking at the presence of pre-injury developmental disorders, such as high-functioning autism, i.e. Asperger's, and persistent post-concussive symptoms, as well as increased velocity of symptoms as compared to baseline.
Yeah, off the top of my head, I don't know if recent studies looking at particularly at autism. It'd be a difficult study to do to try to find a large enough sample of autistic children who also sustain concussion, although I think it'd be interesting. I think where we've seen more research in that area has been around learning disabilities and ADHD or attention problems. And certainly there's some evidence to suggest that kids with pre-existing neurodevelopmental disorders of those sorts seem to do somewhat worse after concussion. But a lot of those studies haven't included a comparison group. So we don't know whether or not the difference between kids with pre-existing neurodevelopmental disorders and without after concussion is true of all children, because we know that kids with LD and ADHD tend to have comorbid problems, or is it that it actually exacerbates the effect of concussion? I think we need better studies there. What we do know is there was a nice kind of flip the question, which is whether or not concussion results in an increased rate of, say, autistic features or attention disorders. There's a very nice systematic review that Bob Asarno's group published in JAMA Pediatrics, I think it was 2 years ago, that pretty convincingly, I think, showed that the rate of so-called secondary ADHD is not increased in kids with mild TBI or concussion, whereas it is increased in kids with moderate severe TBI. The other comment I would make is that we do have some pretty good data to suggest that kids with ADHD are at increased risk of injury in general, and including concussion. So that interaction between pre-existing neurodevelopmental disorder and the occurrence of concussion, the outcome of concussion is a really interesting question. I think we know a little bit, but probably not as much about autism specifically.
Yeah, I definitely agree with you there. There's a lot of interplay and new research coming about the connection between autism and ADHD and all those other conditions. Just so you know as well, there's a couple of thank yous and compliments to Dr. Yeates in the chat. And since we're getting close to the end of time here, I'll ask just one follow-up question before we kind of close things off, unless I see a couple other questions pop up in the chat. But I wanted to jump back to your slide on return to school. You mentioned that early return to school was associated with a decreasing incidence of persistent symptoms. The natural conclusion I came to, one conclusion I would say that I came to, is because that patients with decreased symptom burdens might be going back to school faster. But I have a suspicion that that's not the whole story here. And I was curious if you think that we should start using return to school and cognitive load and exercises as a potential treatment the same way we do aerobic exercise and return to sport.
Yeah, good question. And those analyses that have tried to look at early return to school, including Rogers and the analysis we did, tried to take into account symptom burden and rule it out. Because of course you're right. I mean, kids who are less symptomatic might be more likely to engage in physical activity or go back to school. But there are a variety of ways statistically, short of an RCT, where you try to control for that sort of predisposition. Lots of different approaches to do it, and they took several different ones in the 5P affiliated study. And so even when you control for symptom burden, you do seem to see a positive effect of earlier return to school. And I think that accords with our clinical experience, which is that if you keep kids home from school for a long period of time, they can become school avoidant, school fearful, and also just missing school, particularly for adolescents, can have really significant effects downstream, because it's very hard to catch up in many cases. So I think while we don't have RCT level evidence, and frankly, I don't know if we'll ever be able to do an RCT about early versus late school return, given some ethical concerns, I think we have pretty good evidence to suggest that getting back to activity is a good thing and promotes recovery. To the second part of your question, I actually do think that we may see trials trying to look at whether, in the same way that early exercise seems to have benefits, whether early cognitive activity seems to actually have benefits. Certainly our study of screen time suggests that some moderate level of cognitive activity, although some people would say screen time is absence of cognitive activity. I think in many cases for kids, it actually is social engagement and other things, might have a benefit. So the question is finding that, I think, that sweet spot. What's a good level of activity, promote activity, a certain willingness to deal with a certain level of symptomatology, trying to avoid the sense that having symptoms means your brain is injured. It's just a normal process of recovery, and setting those expectations. I think we will see that going forward.
Yeah, I absolutely agree. I think it's untapped and very interesting. But that is it for our presentation today. Thank you so much once again, Dr. Yeates, for coming on. This meeting is recorded if anybody wants to go back and listen to it later. But for now, we can say goodbye and thank you for attending.
Thanks, everyone.